Hello students, this is Dr. Ganesh, Assistant Professor from the Department of Conservative Dentistry and Endodontics. Today we will be seeing about calcium hydroxide in endodontics. Going into the class, these are the contents we will be covering today. First is the introduction, followed by history, properties, therapeutic action, theories of mineralization, types of vehicles and their importance, dispensing systems, methods of application, use of calcium hydroxide, conclusion, and followed by reference. So moving into the introduction, the formation of dental bridge is an exposed pulp surface and it is now considered the golden standard for direct pulp capping agents. It is a strong alkaline substance which has a pH of approximately 12.5. So let us have a look into the history. In 1838, Nygren introduced calcium hydroxide for the treatment of fistula dentalis. This was followed up in 1934 to 1941. The first report of pulp healing using calcium hydroxide in literature was introduced. In 1936, Hermann used it for pulp capping. Later in the year 1983, Garcia stated that it promotes healing of vital pulp and periapical tissue by hard tissue deposits. Moving on to the properties of calcium hydroxide, it is antibacterial. It has a high alkaline pH around the range of 12.5 to 12.8. It is a strong base. It is soluble in water. The solubility increases in acid and it is insoluble in alcohol. The solubility decreases with rise in temperature, which is important. And the osteogenic and dentinogenic potential is very high. It has a molecular weight of around 74. Next, moving on to the chemical reaction, which is very important. Combustion of limestone between 900 to 1200 degrees Celsius causes the following chemical reaction. Calcium oxide formed is called quicklime and has a strong corrosion ability. When calcium oxide contacts water, the following reaction occurs, which leads to the formation of calcium hydroxide. The classification based on the ingredients is classified as dry powder. It also can be classified as two-phase system, one-phase system, and liqueur. Moving on to the dry powder, it is available in a jar or bottle. It is mixed with a vehicle to form thick paste. They can also be applied in pure form without any vehicle. Liqueur calcium hydroxide, it is formulated by Stanley. Calcium hydroxide plus fillers of barium sulfate dispersed in urethane dimethacrylate resin contains initiators like camphorquinone. It is activated by light of wavelength 400 to 500 nanometers. Moving on to the two-phase system. The two-phase system consists of a base paste and a catalyst paste. The base paste contains glycol salicylate, which is 40%. It reacts with calcium hydroxide and zinc oxide. Calcium sulfate followed by titanium dioxide, which is an inert filler, and also calcium tungstate, which provides the radio opacity for the paste. Moving on to the catalyst paste, calcium hydroxide 50%. It is the principal reactive ingredient. Followed by zinc oxide, which is around 10%. Zinc stearate is around 0.5%, which acts as an accelerator. Next is followed by ethylene toluene, which is a carrier and a plasticizer. Moving on to the one-phase system. It is supplied injectable in a single-phase system. The liquid system, it contains compounds of calcium hydroxide suspended in a solvent. Resinous solution of calcium hydroxide is used as a liner. Moving on to the types of vehicles, it can be classified into three types. The first is the aqueous solution, followed by viscous and followed by oily solution. The ideal vehicle should, according to Favreau in 1991, allow gradual release of calcium hydroxide, calcium ions and OH ions. Allow slow diffusion in the tissue with low solubility in tissue fluid. Have no adverse effect on induction of hard tissue deposition. Next is the aqueous vehicle. It has a rapid release of calcium and oxide ions. It has high degree of solubility. It may be emptied in a short period, delaying healing process. For example, water, saline, anesthetic solution, Ringer's lactate solution, methyl cellulose, sodium lauryl sulfate. The trade names Pulpadent and Hypocal are common examples. Next we have the indication, and this is according to a review article by Favreau et al. The first indication is it should be vital for capping of vital pulp tissues after pulpotomy. It is followed by external inflammatory root resorption. Third indication is endodontic retreatment after endodontic or surgical failures. Fourth, adding lead mix to calcium hydroxide saline paste to be used after pulpotomy to reduce post-operative pain and inflammation. 5. Long-term dressing in non-vital teeth with large periapical lesions. 6. In non-vital infected teeth with cutaneous sinus tract. 7. Anesthetic solution indicated for human apexification procedures and as a pulp capping material. Moving on to the viscous vehicle. It releases calcium and oxygen ions more slowly for extended periods. Lower solubility of paste because of high molecular weight. It remains in the root canal for about 2 to 4 months. For example, glycerin. Trade names can be Endocal, etc. The higher concentration of these vehicles may release the effectiveness of calcium hydroxide as a root canal medicament. Moving on to the indications. Glycerin for root enclosure of immature non-vital teeth. Camphorated paraformophenol to calcium hydroxide plus or minus glycerin paste to extend its antibacterial spectrum. Chronic abscess with extraoral fistula. Internal resorption with or without root perforation. Repair of fractured root. Moving on to the oily vehicles. It has the lowest solubility and diffusion of the paste within the tissue, used only where slow release of ions is required. It is difficult to remove and leave a residue on the canal walls, thus affecting the adherence of the sealer or other materials used to fill the canal, which is very important. For example, olive oil, silicone oil, eugenol and some fatty acids such as oleic, linolenic acids. Trade name Metapex. So what are the indications of it? Perforation defects after internal resorption, reversal of external root resorption, and intercanal dressing in case of non-vital teeth with associated large periapical lesion, and also apexification. Methods of application. Instruments can be used depending on handling, convenience, size and location. Backside of the spoon excavator, lentinospirals, messing gun, Mexpad and compactor, K-type ultrasonic files, pre-fitted pluggers and also ultrasonics. So what are the methods of placement of intercanal medication, or how can we do it? After the access cavity filled with the paste by means of a spiral, or it is layered with the paste, rotated at 500 rpm on a contra angle, then withdrawn in a continuous movement while contact was maintained with the surface. It is inserted crown down until the working length is measured. Until the entire working length of the canal less than 2 mm is achieved. The paste was condensed crown down through using manual plugger, then dried and compacted with a blunted paper point. The operation was repeated until the canal was filled. So this is an article stating the efficacy of 3 methods of inserting calcium hydroxide base paste in root canals. It was given by Galvao et al. They concluded that the canals filled with rotary lentinospirals or conventional technique using a hand instrument had less void compared to techniques combining conventional hand files with sonic activation through endo-activated device. They concluded that a combined approach utilizing hand files with sonic activation showed no enhancement over the rotary lentinospiral or conventional techniques. Moving on, how can we retrieve calcium hydroxide paste that we have applied? Vehicles used to carry may affect its retrieval. 17% EDTA and 10% citric acid can be used. 10% citric acid is better in removing oil-based calcium hydroxide paste. This could be because that the EDTA chelates calcium ions in water, but citric acid is able to penetrate the silicone oil better. The powdered form in distilled water was removed effectively 96 to 99% compared to 73 to 89% in silicone oil containing Metapex. This is an article comparing the different irrigation and agitation methods for removal of 2 types of calcium hydroxide medication. This was given by Deepak et al. They concluded that the removal of calcium hydroxide was best achieved by sonic agitation using endo-activator followed by passive ultrasonic irrigation, manual dynamic agitation and conventional syringe irrigation with side-vented needle. Next we have an article stating the ultrasonically activated irrigation to remove calcium hydroxide from apical third of human root canal system. It is a review article. This was given by Yahali et al. They concluded that the ultrasonically activated irrigation was found to be superior to syringe irrigation. Next, moving on, we have an article discussing the effectiveness of 4 different techniques in removing intracanal medication from root canals. They concluded that the canal brush and ultrasonic techniques showed significantly less residual calcium hydroxide than irrigants and rotary techniques. Tazdemir et al. Showed the canal brush was effective in removing calcium oxide from the root canals than irrigation only techniques. Next is the mode of action. First is the antibacterial activity. It is mainly due to the following facts. It is due to the release of hydroxyl ions in an aqueous environment. Hydroxyl ions are highly oxygen-free radicals that show extreme reactivity with several biomolecules, mainly affecting cytoplasmic membranes, proteins and DNA. It has a high pH. Calcium hydroxide is not effective against all bacterial species found in the root canal infections. Association with other medicaments may enhance the efficacy of the intracanal medication in eliminating residual bacteria in the root canal system. Moving on to the mechanism of action. The first mechanism of action is by damage to the bacterial cell wall. Hydroxyl ions induce lipid peroxidation, resulting in destruction of phospholipids present on the cell wall. Next is the protein denaturation. Alkaline pH induces a breakdown of ionic bond that maintain the structure of the protein. Next is the damage to the DNA. Oxide ions, OH ions react with bacterial DNA and induce splitting of the strands. Next, we have an article stating the effectiveness of calcium hydroxide on bacterial endotoxin in vivo study. The authors concluded that the bacterial endotoxins cause periapical lesion and that calcium hydroxide detoxified the lipopolysaccharide in vivo. Next is the effect on fungi. Fungi have occasionally been found in primary root canal infection, but they appear to occur more often in retreatment cases. Candida albicans is by far the fungal species most commonly isolated from infected root canals. The combination of calcium hydroxide with camphorated pharmachlorophenol or chlorhexidine have the potential to be used as an effective intracanal medication for cases in which fungal infection is suspected. Synergism between calcium hydroxide and sodium hypochlorite. The pretreatment of root canals with calcium hydroxide enhances the tissue dissolving capability of sodium hypochlorite, and this may confer an advantage to multiple visit root canal treatment where sodium hypochlorite would be used following a period of calcium hydroxide medication. Next is the antibacterial effect of calcium hydroxide combined with chlorhexidine on Enterococcus faecalis. This article concluded that the result of the present meta-analysis showed chlorhexidine does not increase the antibacterial effect of calcium hydroxide. So what are the applications of calcium hydroxide? In conservative dentistry, it is used as a liner, sub-base. It can also be used as a pulp capping agent in direct pulp capping and indirect pulp capping. In hypersensitivity, in pin treated restorations, if pin penetration is close to the pulp. Liner or a sub-base. Mazuk et al. Defined cavity liners as film forming materials that carry therapeutic agents which create their greater film thickness and usually applied to dentin only. Moving on, calcium hydroxide liners should only be used in the deepest spots in the cavity where the remaining dentin thickness is less than 0.5 mm. A protective layer of resin modified glass ionomer should always follow the application of calcium hydroxide liners. There are some drawbacks with calcium hydroxide. For example, calcium hydroxide liners have low thermal conductivity. High solubility and water absorption results in softening of the liner, and under poorly sealed tooth restoration interface where the oral fluids can penetrate through and partially or totally dissolve this pulp. Calcium hydroxide liners should not be acid edged, as it might be softened and smeared over the walls of the cavity, which may contaminate acid etched enamel and produce an inferior bond. This is an article in which a calcium hydroxide liner was analyzed. Is a calcium hydroxide liner necessary in the treatment of a deep caries lesion? They concluded that the available literature demonstrated that this material has no beneficial influence and the clinical success of selective or stepwise removal of caries tissue for permanent teeth. Evidence of very low quantity indicated that calcium hydroxide liner would have no effect on clinical success of deep caries lesion treatment. In hypersensitivity, calcium hydroxide may block dentinal tubules or promote peritubular dentin formation. Higher the concentration of calcium hydroxide around the nerve fiber results in lower nerve excitability. Therefore, calcium hydroxide may be capable of suppressing nerve activity. Throbinger and co-workers found that the application of calcium hydroxide to the walls of deep cavities had no effect on the excitability of nerve fibers on the underlying pulp. Lavin et al. Found it to be effective in reducing sensitivity by 98% cases. Next, the desensitizing effect of calcium hydroxide and magnesium hydroxide and hypersensitivity dentin. This was given by Marvin et al. They concluded that the best results were obtained with calcium hydroxide group, where less than 2% reported no relief after 6 months. However, the control groups reported more than 40% complete relief during the same period. Direct pulp capping. Direct pulp capping is defined as a procedure in which pulp is covered with a protective dressing or base placed directly over the pulp at the site of exposure in an attempt to preserve its vitality. When calcium hydroxide used as a pulp capping agent and in apexification cases, a calcified barrier may be induced. The exposed pulp is capped with calcium hydroxide. Glass ionomer liner and composite resins are also used in the restoration of the tooth. Moving on to the mineralization activity. The hydroxyl group provides an alkaline environment which encourages repair and active calcification. The alkaline pH induced not only neutralized lactic acid from osteoclast, thus preventing dissolution of the mineral components of dentin, but also active alkaline phosphatase that play an important role. Alkaline phosphatase is a hydrolytic enzyme. It can separate phosphoric esters, freeing phosphate ions, which then react with calcium ions from the bloodstream to form a precipitate, which is calcium phosphate in the organic matrix. Immediately, a small necrotic zone is created bordering the pulp side of the small basophilic layer of calcium proteinate, which shows how far calcium hydroxide has penetrated into the pulp. After 4 weeks, necrotic zone disappears, gradually leaving an empty space. After 8 weeks, a layer of 0.1 mm of dentin is formed. After 6 months, the dentin bridge will reach the thickness of 0.3 mm, and this can be seen well on an oriented radiograph. So what are the tunnel defects in dental bridges? Tunnel defects is voids present in the dental bridges. These patterned tunnels fail to provide a hermetic seal to the underlying pulp, resulting in infection due to microleakage. Most calcium hydroxide medications have been reported to disintegrate and wash out after 6 months, leaving a void underneath the restoration and thereby a pathway for bacterial infection. So next we have an article, direct pulp capping with calcium hydroxide, mineral trioxide aggregate and biodentin and permanent young teeth with caries. They stated at the follow-up examination at 1 week, the patient showed up to 100% clinical success. At 3 months, there was 1 failure in the calcium hydroxide group. At 6 months, there were 4 failures. Although no significant difference were found among the materials studied, biodentin and MTA showed advantages over calcium hydroxide. Next is a review suggesting direct pulp capping with MTA more effective than calcium hydroxide. This was given by Lakshmi et al. In the year 2016. MTA has a higher success rate and results in less pulpal inflammatory responses and no predictable hard dentin formation than calcium hydroxide. MTA appears to be suitable replacement of calcium hydroxide used for direct pulp capping. Next is the effect of mineral trioxide aggregate, calcium hydroxide, biodentin, mTOR on osteogenesis. This was given by Yosef et al. All capping materials showed variable cytotoxicity against cytotoxicity. Results suggest MTA, biodentin and mTOR exhibit similar attributes and may score better than calcium hydroxide. mTOR could be a promising alternative to MTA and biodentin in enhancing pulpal repair following dental pulp injury. Indirect pulp capping agent. It is defined as the application of medication over a thin layer of remaining caries dentin with no exposure to the pulp. It is recommended for teeth that have deep caries lesion in close proximity to the pulp. Removing outer layer containing majority of microorganisms reduce demineralization of deep dentin and also pulp to regenerate reparative dentin. Next is the clinical performance of a mineral trioxide aggregate versus calcium hydroxide as an indirect pulp capping agent. This was given by Govula et al. In the year 2019. This systemic review of the available evidence reveals that MTA and calcium hydroxide demonstrated good consistent endurance in clinical studies and indistinguishable performance. So what are the use of calcium hydroxide in endodontics? It can be used in pulpotomy, intracanal medication, as an adjunct to canal irrigation, treatment of weeping canals, repair of perforation, traumatic injuries, root canal sealer, apexification and apexogenesis. Pulpotomy. It is defined as the complete removal of coronal portion of the dentin pulp followed by placement of suitable dressing or medication. The alkalinity, biocompatibility and antimicrobial activity of calcium hydroxide is suitable material for pulpotomy. It can also be used as an intracanal medicament. By remaining in the canal between appointments, intracanal medication may help to eliminate surviving bacteria. So what are the effects of calcium hydroxide on dentin? Use of calcium hydroxide dressing for 5 weeks or more causes a decrease in root fracture resistance. This could be due to denaturing of organic matrix due to high pH, and since the organic fibrils are encapsulated by inorganic hydroxyapatite, it takes some time for calcium hydroxide to penetrate, causing the dentin to be more brittle and more susceptible to fracture. Next is the pH changes in root dentin over a 4-week period following canal dressing within a calcium hydroxide. This was a study done by Novich et al. The results indicated that after 1 to 7 days, hydroxide ions took 7 days to reach the outer dentin. After 7 days, pH was around 9 pH at a level which may bacteria fail to survive. After 3 weeks, they reach peak levels and stabilize. Bacteria may survive after intracanal medication with calcium hydroxide for several reasons. Resistance of bacterial strain to the medicament, tolerance of certain bacteria to higher pH, bacteria enclosed in anatomical variation inaccessible to the medicament. The effect of the medicament may be neutralized, low solubility and diffusibility of calcium hydroxide. What are the difficulties associated with calcium hydroxide as an intracanal medication? It may not penetrate inaccessible anatomical areas. It may not penetrate tubules because of bacterial biofilm. Ability of E. faecalis to colonize the tubule and thus evade OH ion. Difficulty in removing calcium hydroxide from the canal. So, calcium hydroxide as a sealer. This is a review article by Desai et al. From the year 2009. Most studies concluded that the biocompatibility of calcium hydroxide based sealers were within the acceptable range compared to other root canal sealers. Antimicrobial action of calcium hydroxide based endodontic sealer after setting against E. faecalis biofilm. Based on the results, it can be concluded that E. faecalis biofilm was not completely eliminated regardless of the sealer used over a long period of time. Root resorption. Hard tissue resorption with this enzymatic activity takes place in acidic pH. Calcium hydroxide creates an alkaline environment in which reaction is reversed and hard tissue deposition can take place. It reduces osteoclastic activity and stimulating repair. The effect of calcium hydroxide and inflammatory root resorption was analyzed, and they concluded that in comparison with enamel matrix derived protein, Oliver et al., quantification of resorption revealed that Emdogain treated tooth showed a low percentage of resorption than calcium hydroxide treated tooth. Periapical lesions. Periapical granuloma may be formed by immunological response of the apical tissue to chronic infection within the root canal. Calcium hydroxide dressing controls the passage of periapical exudates into the canal, thus allowing the placement of satisfactory root filling. Calcium oxide also accelerates the natural healing of periapical lesion regardless of the bacterial status of the root canal at the time of placement of the material. It reduces the seepage, probably due to the fibrous barrier that is formed when calcium hydroxide is placed in direct contact with the host tissue or simply in effect of mechanical blockage. The influence of calcium hydroxide as an intracanal dressing on the prognosis of teeth with endodontically induced periapical lesion. They concluded that from a microbiological perspective, one visit root canal treatment created favorable environment condition for periapical repair similar to 2-visit therapy with calcium hydroxide. So, calcium hydroxide as a medication for weeping canals. Tooth undergoing RCT show constant clear or reddish exudate associated with a large apical radiolucency. Tooth can be asymptomatic or tender on percussion. With open in the next appointment, exudate stops but again reappears in the next appointment, which is a classic example for weeping canal. This is known as weeping canal, and culture report shows negative bacterial growth. So, for this treatment, dry the canal, place calcium hydroxide paste in the canal. Mechanism of action: high pH calcium hydroxide neutralizes the acidic pH of periapical tissue. The calcium ions reduces the permeability of a new capillary, thereby reducing the serum flow within the pulp, thus increasing the concentration of calcium ions at the mineralization site. Root fracture. In the management of horizontal root fracture, the coronal segment is considered as an immature tooth with an open apex, and an apexification procedure is considered. Calcium hydroxide and MTA both can be used. An apexification is defined as a process of creating an environment within the canal and periapical tissue after pulp death that allows the calcified barrier to form across the open apex of an immature tooth. The use of calcium hydroxide for apexification in the pulpless tooth was first reported by Kaiser in 1946. In regeneration, calcium hydroxide was the first agent to be used in regenerative pulpotomy because of its ability to form hard tissue barrier. Recently, the regenerative capacity have been questioned owing to the fact that tissue response is more reactive than inductive. Mostly recommended for pulpal primary teeth, studies have shown that MTA to be equally effective as calcium hydroxide and a partial pulpotomy agent. What are the recent advances? Nano calcium hydroxide. Nanotechnology provides the advantage of reducing the size of the particle as well as increasing the efficacy. Because of its smaller size, they can reach the complex anatomy of the root canal system. The higher surface area and higher charge density lead to greater interaction with the environment, negatively charged bacterial cell wall. Nanosized calcium hydroxide particles have higher levels of antibacterial activity in comparison with the conventional calcium hydroxide. So, the effect of calcium hydroxide and nano calcium hydroxide on micro hardness and superficial chemical structure of a root canal was studied. This was given in the Journal of Endodontics in the year 2019. The changes in micro hardness were limited in NH group in comparison with the calcium hydroxide group, which suggests a possible replacement of NCH as an intracanal medicament for the preservation of intact dentin structure. So, to conclude, it has a high pH and its dental use relates chiefly to its antibacterial property, degrades residual organic tissue, making it more susceptible to dissolution by sodium hypochlorite. It has the unique potential to induce mineralization and has been used for various treatment in dentistry and still continues to be the most frequently used material. So these are my references, and thank you for listening to my class. Have a wonderful day.